Good morning, friends and colleagues, my teachers. I have great pleasure in welcoming you to this 10th series of webinar where we present interesting cases from different institutions. And today we have the honor of having to listen from the presentations from JIPMER Puducherry. And it's my pleasure to introduce the chairperson for this meet, Professor R.M. Bhupati. Professor Bhupati is a friend and a close colleague of mine. We have worked for years together. And at present, he is the professor and head of the Department of Neurology at Omandurar Super Speciality, Multi-Super Speciality Hospital in Chennai. Professor Bhupati is a very experienced clinician, takes great, what should I say, great interest in clinical neurology, as it would be evident from his discussions. And it's indeed a pleasure to have him chair this meeting. And I welcome Professor Bhupati and request him to conduct the proceedings further. As all of you know, he is also a PhD, having obtained his PhD on epilepsy. And as I said, he's a great clinician. Yes, Professor Bhupati, you can take over and conduct.
Thank you, Professor Natarajan, former director and present
Sir, allow me proceed.
Clinician, academician. We should give credit to your continuous academic activities in years together. Anyway, the same time, I welcome Vaibhav, Professor Vaibhav, and other presenters.
Good morning, sir.
Dr. Rajput. Thank you very much, sir. I invite Dr. Rajput to present his case. Dr. Rajput.
Sir, the first case will be presented by Dr. Bidan. They are presenting from same computer. The first case is by Dr. Bidan. Bidan Mandal.
Yes, Dr. Bidan.
Yes, sir. Yes, sir.
So, sir, first of all, let me thank both of you, Dr. Natarajan sir and Bhupati sir, for welcoming us and for giving JIPMER a chance to present on this forum. And we need more and more such clinical forum. Wish you all a very healthy new year. And let us begin with the presentation. Dr. Bidan, yeah, please.
Yes, sir. Sir, allow me to share, sir, screen.
Sir, you can share, sir. Already shared.
Now you can share, sir. I stopped, sir. Now you can share. There's one green color, share screen, green color.
Can it visible, sir?
Yes,
Yes,
you are
sir,
visible.
yes.
Make a slide presentation, yes.
Good morning, everyone. Today I am presenting on case, a young patient with muscle weakness. The patient is actually 19 years old male. He is right-handed and resident of West Bengal, Howrah. And he is a student of BSc Computer Science. And the case informant is patient himself and his mother. The presenting complaints are difficulty in getting up from sitting position for 9 years, giving away of both knees for 9 years, thinning of both thighs for 4 years. This difficulty in getting up is first noticed by his sports teacher, where he that time transferred, and this teacher during his sports session has found that he could not perform squatting exercise, and while doing that he fell down. When he running with with friends, whenever he has to run more than 100 meters, he has to sit down, and after sitting down, while he getting up, that time he started to needed one hand support. So after that he has called his parents and he told that After that, this problem is gradually progressive, and after 4 years, he need both hand support to get up. He also, that same time, he also had difficulty in using staircase. It's more difficult for him to going down than up climbing the stairs. And it is also progressive. For the last 4 years, he used his both hand, one hand in railing and one hand in wall, to climb up and climb down. This giving away of knees also for 9 years. Initially, he has frequency of fall is 2 to 3 per week, and he sat down, maximum time he sat down to avoid fall. For the last 2 years, the frequency reduces 1 in 3 months. From the history, it is looking like that he actually now modifies his activity. Yes, sir.
Huh? Okay. See, you start the conversation and say you drop. What does it say? Tell me, no?
I wanted to know how to say that I'm watching the conversation.
You're watching, you're
Your
listening.
interest.
You're there. Your name will be there. Go to participants.
Hello.
Go to participants. You have that, no? Your name will be there.
Yeah, it is there. So what do I do?
That's all. You're listening.
Do I press it?
No, you're participating. That's all. You
Hello,
close
sir.
it. Everybody knows you're participating. Because you're there.
Hello, sir.
Hello.
Sir, you are in, sir. Can you mute yourself, sir, please?
You want me to mute myself? I don't know how to mute myself.
Sir, there will be a button there asking you to mute and unmute. You just press it, you will get muted. Yes, sir, you are muted.
For the last 2 years, he actually modified his activity so that the frequency reduces 1 in 3 months. This is also noticed after the 4 years. He noticed that whenever he sit with one leg over other thigh, the ankle hangs loosely. So with that history, he has no difficulty, no history of neck muscle weakness, no history of history suggestive of distal muscle weakness of the lower limb, that holding sleep chappals, and he also no history suggestive of proximal and distal muscle weakness of the both upper limb. He has no history suggestive of facial muscle weakness, like sucking with a straw, blowing off candle, and whistling. There is no problem. He noticed that thinning of thighs for the last 5 years, it's mainly the inner aspect of the both thighs, and that he is telling equal to both sides. As per his comment, he is telling it is slowly progressive, but he cannot support his comment with any evidence. He has no difficulty in releasing object after holding. There is no history suggestive of fasciculation, cramps, any contracture, any other rippling of muscles. There is no history suggestive of fatigability, diurnal variation, and any other history of dark urine. No history suggestive of radicular pain or any sensory symptoms. No history suggestive of any cardiac illness. There is no history of autonomic symptoms, no cranial nerve symptoms, no higher function abnormality, or no history of any gynecomastia, no history suggestive of autoimmune illness, hypothyroidism, or tuberculosis. And as per his current status, he is doing all his duty, all his routine works. He is studying BSc, as I previously told. He walks without support. He rides bicycle, and in fact, he can swing also. But he uses his hands more than his legs. He has past history suggestive of allergic bronchiolitis in the early childhood. No history of any BiPAP use, or there is history suggestive of frequent seasonal variation, and it is responsive to the nebulization. It improved after 5 years of age. This is the family tree. This is the patient. And as per this is the non-consanguineous marriage we can see, and this his father's elder brothers has two child, one 11 years old girl who has no problem, but his son has autism, that is 7 years old, and his from mother's side his mother's younger sister has one male child, single male child. He suffered from angst bond, and that is he is 11 years old. He is now on treatment from Jipmer. So in summary, we can see that he has difficulty in getting up from sitting position, difficulty in climbing stairs, falls, also giving away due to buckling of knees, thinning of thighs, and floppiness of ankle. This one hand, from the at the age of 10 years, he can get up with one hand support, and the falls are 2 to 3 per weeks, and it is more problem is in downstairs to upstairs. After the 4 years, he started to use both hands and started using railing of walls. There is started thinning of thighs. He noticed floppiness of ankle. At the last 2 years, for the last 2 years, this falls actually he modified his work like that. So this falls has been decreased, and he is quite ambulatory. He's quite capable of doing all his works at present also. So in summary, this is chronic, insidious, childhood onset, slowly progressive, symmetrical, proximal, lower limb predominant, LMN, pure motor weakness. LMN, as there is history of floppiness of the both ankle and wasting of the both thighs.
So, Dr. Vidhan, just a minute. Now, sir, I would invite comments from you and the other delegates also, if there is any comments or at this stage. Am I audible, sir?
Yeah, you're audible.
So now
You're audible.
yes, sir.
How did he get how did he get history of mental retardation? What mental retardation history you asked? What is it you asked?
Sir, mental retardation, first thing is he is very good in scholastic performance. He is actually doing well in his BSc computer science, and he has no history of any poor scholastic performance, any day-to-day activities. There is nothing is there. That's why I told it is he is not mentally retarded.
Now you asked for developmental delay or language delay.
It is not there, sir.
It was not that. Yeah.
Not
you
there.
asked from beginning.
Yes, sir. Yes, sir. Yes.
Because nowadays it's very easy to get a degree. The patient may say that I have finished my BBA.
Yes.
I have done several degrees you easily get.
Yes, sir.
But even in children, we have seen in the Corona period, the child is studying 10th standard, 12th standard, and the parents will say, and you ask him to write in a paper, what is his name? He will not be able to do it. So like that, no, this is what, just because he gets a degree does not mean that he is little delayed scholastically.
Yes.
That is why I asked, yeah. You should ask from the beginning.
Yes. Should I proceed, sir?
So can we proceed, sir?
If anybody volunteers, see, principally it is a weakness involving the lower limbs, and that too involving
Yes.
certain select group of muscles.
Yes.
Probably the quads group as well as the dorsiflexors of the ankle, that is the tibialis
Yes.
anterior, and that she is better off climbing stairs than going down should suggest that the gluteae are also involved. So these
Yes.
are the muscles which seem to be selectively involved in this patient, and so we should focus on
Yes.
a myopathy which is involving these muscles and which is progressing starting at the age of 10 years and going on for the last 9 years now, associated with thinning of the muscles also.
Yes.
So what is thinning? Is it an indication that it is neurogenic, or is it still a myopathic problem is what we need to consider. And so as usual, we would consider it a low motor neuron
Disorder.
muscular
Yes.
neuromuscular problem, which
So-
includes both of these.
Yes, now we'll be proceeding with that, this detailed analysis. Now we proceed with the analysis of the symptoms and everything. Yeah, proceed with that.
Yes, yes, sir.
So the difficulty in getting up from sitting position, we can take it is a proximal muscle weakness, and giving away of knee with falls, it is more of quadriceps knee extensors weakness, thinning of thigh, that is inner aspect, that is muscle wasting, and floppiness of ankle, it is reduced tone. So localization is as there is no sensory involvement and no fasciculations, so we put it muscle first, then but we cannot rule out at the stage all the things. So we are keeping all the possibilities: muscle, nerve, anterior horn cell, and neuromuscular junction. In favor of muscle, there is actually proximal more than distal weakness, and this weakness is out of proportion that wasting, and no sensory symptom is there. There is differential weakness in form of buckling of knees, and there is actually no against point in the muscle. So in nerve, there is proximal as well as distal weakness and floppiness of ankle also there. In against point, there is no sensory involvement, no upper limb involvement also there. And in HC, there is no sensory involvement, no sensory symptoms, proximal and distal weakness with ankle floppiness. And against point is there is less muscle wasting and no fasciculation or polyminy microsis is not there. No neuromuscular junction, there is proximal weakness in favor of no sensory, no profound wasting, and in against point, no fatigability, no diurnal variation. So in case of muscle, we should think of LGMD, congenital myopathy, or dystrophinopathy. In case of nerve, there is, we can think of HSMN, as there is very little sensory symptoms is there. We can think of CIDP, motor predominant CIDP also. In AHC, SMA4 also can be possible with bilateral symmetrical proximal LMN weakness. In MJ, we can think of limb girdle variant of CMS, that is DOC7. On general examination, this boy is average built, well nourished, with BMI of 21 kg per meter square. Pulse rate is 84 per minute, regular and equally palpable in all four limbs. BP is 100 per 66 millimeter of mercury. No neurocutaneous marker, no gynecomastia is there. In respiratory system is also normal, with no indrawing of intercostal muscle, no paradoxical breathing, and chest wall expansion at inspiration is at maximum inspiration it is 4 centimeter. GI and CVS system also normal. On seeing, we can see that this is a elongated face with some micrognathia is there, and ear is not low set. There is high arch palate is present. Higher mental function is normal, and his MMSE score is 29 per 30. He actually cannot tell the floor, other part he told and done great. Cranial nerves also normal. We can see that in picture. The eyelashes are buried in the both eyelid, so there is no facial weakness, no neck muscle weakness. Bulk, here it is actually bilateral thighs. In the picture actually it is not clearly visible, but there is wasting of the thighs is there. In video we can see better, and there is preserved EDB, no fasciculation, no myotonia, but tone is flaccid in all four limbs. Here we can see there is preserved EDB, and we can see there is wasting of the thighs. Here we also can see the thigh and cup muscles and hamstring muscles also somewhat wasted, but it is bilateral symmetrical. On upper limb examination, there is no scapular winging, and shoulder, elbow, wrist and finger, it is actually power wise, it is 5/5. On movement of the hip joint, the flexors are 4 bilateral, extensions are more weak than flexors, that is 4 minus, and abduction is also 4. Other movements are 4. Gower, it is actually not full blown gower is present, but he cannot get up. He cannot get up on his own. He is taking both hands support to get up. He is not putting his hands in the thigh. So it is typically, it is not present. Movement at the knees, it is actually hamstrings are 4 and quadriceps are 4 minus. You can see at least it is 4. We can see the dorsiflexors are also quite well preserved. This is the hamstrings. But we can see that hypotonia in the both ankle. You can see here there is wasting of the medial aspect of the thigh with some bulging of the muscles in the thigh muscle. That is, yes, sir.
Vedant, so here you have to highlight that there is a selectivity in the muscle weakness. So this is a diamond sign.
Yes,
And
sir.
previously also you forgot there is a main, although the whole legs are wasted, thighs are wasted and the legs are wasted. But there is selectivity, the adductor side is more wasted in this also. The selectivity on the muscle.
Yes, sir.
And apparently in the diagram, which both the figures we showed, it is not very grossly visible because he is a gym going person. But when we compare this wasting of lower limbs, the lower limbs are extremely thin, especially when we compare it with the upper limb.
Yes.
So the whole leg and thigh are wasted with selectivity also.
Yes, sir.
So all this needs to be highlighted. Okay, proceed.
This is actually occurs. This diamond signs occurs due to selective wasting of the upper part and lateral part of the vastus intermedius and vastus lateralis. The medial part actually preserved. This is intramuscle specificity, for which whenever patient contracts, there is visibility of the middle part of the muscle. So we can already seen that ankle plantarflexor and dorsiflexors also 4/4, and this tibialis posterior is actually its power is 5/5, and peroneus longus, that is and brevis, that is flexion and eversion, it is 4/4. Here we have done the beaver sign. It is actually negative. So the abdominal muscles are not weak.
It is important to see beaver sign in this case because there is some amount of facial dysmorphism. We were suspecting a facial weakness. So although nothing is giving strongly in the favor of it, there is no scapular involvement, but FSHD was one of the differentials, and beaver is associated with FSHD, facioscapulohumeral dystrophy.
Yes, sir.
So beaver is also not present.
Reflexes are quite well preserved, with knee actually 1+, bilateral knee is 1+. However, on activation maneuver, it is actually coming nicely. The other system, sensory coordination, no normal. There is no abnormal movement. Spine, cranium also normal. This is the gate of the some amount of waddling we can tell. Otherwise, it was normal.
No, despite this long course, waddling is minimal, if at all we can say.
Yes, yes,
Almost
sir.
absent. Yeah.
Slowly. So, in summary, with history and examination, this is a 19 years old boy born of non-consanguinity with insidious, slowly progressive, symmetrical, pure motor element weakness. This lower limb also showing showing some differential selectivity, that is knee extensor more than knee flexor and hip extensor more than hip flexor, iliopsoas, hip abductor, adductor and ankle dorsiflexor weakness with retained reflex, with some facial dysmorphism, with high arch palate, with wasting of thigh, legs, with preserved EDP. There is diamond sign also there, without any higher mental function, sensory, cerebellar or autonomic involvement, without any similar history of family in family. Should I proceed, sir?
Yeah, you proceed. You proceed. After this, we will proceed.
So after examination, we found that all the things are in favor of muscle. Only one point is there is some diminished knee jerk. Otherwise, it is proximal more than distal with normal sensory examination with differential intramuscle and intermuscle selectivity is there. In HC, there is points in favor. Also, there is proximal as well as distal muscle weakness, normal sensory examination, but no fasciculation, preserved BDB, and preserved reflexes are against point. Nerve also, there is preserved BDB, no sensory signs, and preserved other reflexes are points against, strongly against nerve. NMJ, there is no fatigability and fluctuation, so it is also quite difficult for this patient.
So before going, previous slide, go to the previous slide. Before going to the etiology, can we invite the comments from the?
Yes, yes, doctor. In your presentation, you are told that initially he was having more frequent falls. After that, the frequency of the falls is reduced. That means what? What do you think? Whether he has restricted his activity or is there any improvement in his original weakness? These are all the two things that you have to highlight. One. Two, the whole thing, see, according to your presentation, it is restricted only to the muscles. If I carefully watch all the findings that you have presented, it is restricted to the muscle itself, and it is that too. You have been telling from the beginning diamond sign positive, diamond sign positive. So it has got a peculiar muscle disease. That's all I can say at this juncture. Please explain why this patient, there is a decreased number of falls, even while he has been growing on. Previously, his number of falls was very, increased number. And as he grows up, as his activities, motor activities increases, the frequent falls has reduced. That has got some sense, I think, in making diagnosis.
Yes, sir.
Before making clinical diagnosis.
Yes, sir. There is already, I told actually, sir, there is some possibilities of reducing the frequent falls. He is actually become aware. First is he is becoming aware of the events, the capability at after which he is going to fall. So some modification of lifestyle is there. First, second thing is, sir, he is actually joined for the last 4 years some physiotherapy and muscle exercise training. for which also can be one cause. And third thing is, sir, in some cases of congenital myopathies also, specific few areas, there is actually for after some time, it actually allows to improve for a long time. These three things I thought, sir, it is the possibilities.
Okay.
See, the selective wasting, which you pointed out, namely the diamond sign being present, suggests this is likely to be a type of dysvallonopathy,
Yes, sir.
isn't it?
Yes.
Yes, sir.
Specific dysvallonopathy,
Yes, sir.
which could either be LGMD itself, limb-girdle muscular dystrophy, wherein the adductors are more involved, if distal involvement is not that great, if it were, then we would have to consider a Miyoshi also.
Yes.
So it's between the two that the diagnosis would rest. Either an LGMD or if the distal is prominent, then probably Miyoshi. But I think it's more proximal and it's the adductor tube which is involved. Only thing is the pectoral girdle is not that much involved.
Yes, sir.
So still probably the first would be LGMD 2.
So there was one
or a possibility of a Miyoshi.
There was one additional thing that was bothering in this case throughout to us. That was very severe facial dysmorphism. There was a facial
Yes.
dysmorphism.
Yes.
That was bothersome. We researched it and we could not find anywhere in the dysphallonopathy and all those things. We couldn't find facial dysmorphism. So this one thing was against. And second thing, as you rightly said, the progression, the wasting we could appreciate only after we compared it with the upper limb. The power was hardly any loss. He could complete all his activities. He could bicycle, he could swim, all those activities he could do. So these, what you rightly said, these two were one of our top-notch etiological differentials.
But would you still go ahead with considering an anterior hornsel involvement?
We will discuss it, but it was much lower down and especially the reflex. So Vidhan, just proceed with the next two slides so that we can discuss the etiologies. Okay.
So
So
can
now,
I
where do we stand now? Yeah.
Sir, can I add one more point? The presence of facial dysmorphism strongly denotes chromosomal anomaly. See, there is a history of autism in the family also. If we want to combine both autism and
Hello, you're not audible, sir. Meganand, sir, you're not audible.
if you want to combine both the dysmorphic feature and the history of autism, I had a doubt in my mind whether it is a sort of congenital type of myopathy like Prader-Willi syndrome, which can have Angelman syndrome on one side with Prader-Willi on the other side. There is another possibility where the obesity may not be there in little later age group. There is one more possibility. Still, we have to think, because dysmorphism definitely denotes chromosomal anomaly in this case.
Okay, we didn't have Prader-Willi as one of our differentials, sir. But thank you for the session. We will go back and read it. But the presentation started much later, but there must be some late onset variants.
So due to this prominent proximal weakness, then distal with diamond on quadriceps, we thought of proximodistal variant of dysparlinopathy. And as there is hatchet pace and high arch palate, as sir already told, we also think of congenital myopathy. As
Yeah, the calf was not preserved, right? Calf was wasted.
Yes.
Yeah.
Relative preservation, then proximal that I am to tell. But it is wasted, sir. In SMA, as sir told, young onset proximal symmetrical element, preserved sensory. So we have the feelings that it may be there, but preserved reflex and no fasciculatory tremors is actually very against to the SMA. And Baker's muscular dystrophy, we can think, but cap hypertrophy is not there.
No,
So-
Dr. Bidan, as against the common belief, in SMAs, the fasciculations may not be one of the prominent features.
Yes, sir. Yes.
So that as that fasciculation should not be the one single point where you rule out the SMS. SMS can present without fasciculation also.
Preserved reflex, sir.
Yeah, but preserved reflex is a strong point against it. Yeah. And EDB preservation.
So here we can see that some LGMD subtypes and their distinct phenotypic features we got from Khadilkar sir's book. That is, we can see that joint contracture, it is more on calpainopathy and lamininopathy, and rippling of muscles is more common. Rippling muscles, muscle cramps is avellinopathy. Hip abductor splaying, that is more common in sarcoglycanopathy and dysparlinopathy. And scapular ringing is also, which is not present in here. We can get it from calpainopathy and sarcoglycanopathy. Abdominal muscle weakness, that is abdominal hernia, present with abdominal hernia, can present with calpainopathy and sarcoglycanopathy. This cardiac muscle weakness also in myotillonopathy and sarcoglycanopathy and titinopathy. As as already sirs already told, this diamond on quadriceps are more in favor of LGMD2B, that is dysparlinopathy. So this diamond on quadriceps, we can think of LGMD2B. And so the thing is now congenital myopathy versus dysparlinopathy. So on laboratory workup, CPK was normal, thyroid also normal, and the he is seronegative to HIV, HBsAg, and HCV is non-reactive. NCS, it is fully normal with normal SNAP. RNST also we have done to rule out congenital myasthenic syndrome, that is also negative. EMG has been done, no spontaneous activity with MUPs of myopathic pattern, short duration polyphagic MUPs with early recruitment and full interference pattern, suggestive of muscle disease. MRI we have done. In this MRI, we can see this is gluteus maximus is actually very severely affected. The left side and right side, both side, but it is identical to the left side.
So as the sir rightly pointed out, although clinically we could not appreciate this as the power was always grade 4 in all the muscles. Now here the MRI beautifully shows that gluteus maximus weakness. Sir, earlier in the discussion, when discussing the staircase, beautifully pointed out the involvement of gluteus maximus and quadriceps also. So here it can be clearly appreciated the focal nature of the disorder and differential wasting. Yeah.
Here in the thigh muscle, we can see this is identical to the left side MRI pointed out. Here we can see rectus femoris quite spared, bustus medialis, bustus lateralis, and bustus intermedius also affected. But in the posterior part of the thigh also somewhat grade 2 semimembranous, semitendinous also, and biceps femoris long head and short head also somewhat involved, but it is not as extensive to the quadriceps muscle with relative sparing of the rectus femoris muscle.
Yeah, so on the right is the normal index MRI taken from the literature, and the more the hyperintense is the muscle, the worse it is. So here the differentiation can be seen, like serratus anterior is minimally hyperintense, cerimembranous, semitendinosus, and bicep long head is more hyperintense, and vastus intermedialis and vastus medialis is almost gone. It is very intensely hyperintense. So MRI is a new tool, and here it becomes very apparent, showing the selectivity and wasting. So next is the calf. Proceed with that. Yeah.
Here is also we can see soleus gastrocnemius and the tibialis posterior and flexor hallucis longus is also very much affected. So the cuff muscles also is affected. What we have
So in the examination, there was some doubt whether calf hypertrophy is clear cut there or not. But we were quite in the favor of lower limb atrophy, especially comparing it with the upper limb. So here it can be clearly seen that leg is also involved and posterior compartment is involved more than the anterior compartment.
So now it is clear cut that it is dyspareuropathy versus congenital myopathy. So we have sent clinical exome sequence where we found that it is Nemaline myopathy, autosomal recessive type, which is pathogenic. So here is a great.
So I think we will invite some comments here since we have bring up the diagnosis. So after the investigations and this final investigation of genetic, which is the gold standard, it is reasonable enough to invite the comments from others.
I would like to know regarding congenital myopathies, is there selective muscle involvement? Of course, I know that in Nemaline myopathies, yes, there is an elongated face and prognathism. These are features of Nemaline myopathy and probably helps one identify or think of Nemaline. But the subtle differences between the adductor group and the calf muscle groups,
yes, sir,
whether they get affected in Nemaline or any of these congenital myopathies, that has not been much highlighted. So I would like to know that.
This question was nagging me throughout, sir. I had even searched this, but I could not find anywhere. In the MRI also such difference is not been given. But there is some differential involvement in the MRI patterns of Nemaline myopathy has been given, which Bidan, you have that slide, no?
Yes,
that,
sir. Yes, sir. I have that.
And the second problem here is they have written inheritance as autosomal recessive, which we were expecting. But the problem is here zygosity is heterogeneous. How these two things go together, heterozygous zygosity along with the autosomal inheritance, I don't know. I need to communicate with some genetist also. If there is some genetist listening to here, they can comment. You search that, Bidan?
Sir, I search it actually heterozygous autosomal recessive. Actually, they told there is different genetic mutations in different locus. If it is homozygous, this actually explaining the very slow progression of the disease. If it is homozygous, it will be more severe. So this is actually explaining the things. So there are so many case reports also there which are showing actually heterozygous transmission.
Now, I just want to highlight one more thing to all the forum in this at this point. The right side where the classification is written. Unless there is clear-cut pathogenic written, we should not say it, because nowadays we are going for complete genome exome sequencing. So here the pathogenic is written. So that pathogenic word is important. Uncertain significance is not. So there were two more mutations seen here, but they were of uncertain significance. We have not put that report here. So only one thing has come positive.
I see some pediatric neurologists here.
Yeah, they want to say something. I would love to have their comment. Yeah, please.
Yeah, Dr. Meghandan is there, Dr. Ramakrishnan is there, Dr. Sendil Kumar is there. These are pediatric neurologists, so they can contribute. Professor Bhupati sir, you could ask them.
So, because I am not that expert in this genetic analysis, so somebody could really shed some light here. It would be good.
See, I'm much worried about your examination. See, did you examine the family members? Did
No.
you examine, is there any form of history of muscle involvement in the family members?
No,
That is
mother.
That is more important. That is more, that gives more significant about this your genetic study. That is, you found out that there is some culprit. So if you examine the family members, that is contributing more. It also confirms our diagnosis, gives significance to our diagnosis.
We examined mother, sir. Father was not available. Rest of the patient, we asked them whether facial dimorphism was present in any of the family members. Such species was not present in the other members. And this chap is very intelligent. It is not like only BSc computers he has done. They are quite affluent family and very very reasonable. We can believe their history, what they are saying. So yeah, but I agreed. We should have examined the family members. We have to go back and examine one by one. But mother, we have examined. Mother, there is no facial dysmorphism or any problem. Father, we have yet to examine. And history-wise, there is nothing. But there is one history of autism, and there is one history of ankylosing spondylosis.
We can do genetic studies in family members also sometimes. If you want to present this case, or if you want to write up this case.
Yes. And this question, this question is important here because we have my principle here is to avoid muscle biopsy as far as possible. So since we were thinking as dysphalanopathy as one top diagnosis, we have not done muscle biopsy till now. So the next question will be whether in the highlight of this genetic report, should we go for muscle biopsy or not?
Sir,
That is the next question.
shall I speak, sir?
Yes.
I'm Dr. Ramakrishnan. So the genetic, as you have rightly mentioned, when it is mentioned as pathogenic, it is really important, sir. But this uncertain significance, it depends on the database of the lab, sir. For example, if they have got 1,000 genes of the concerned phenotype we are asking for, and if that is not covered in that, they will mention it as uncertain significance. Probably if you test it in another lab which has got a large database, it might become pathogenic also. This is uncertain significance, means in their database, they are not having the clinical genotype what we are expecting, sir. But what we have to do is, first we have to confirm it by doing a Sanger sequencing. That is, manually they have to check whether this is really clinically significant or not. And we have to do the same gene test in both the parents. That is something called gene trio, sir. NGS trio. We have to see in both the parents. And if you have got this similar gene mutation, then we can take it as pathogenic if it clinically fits in with our diagnosis.
Okay.
They have actually
what we have, Megandha,
study.
you are able to hear me?
Yes.
What we have seen in one or two cases where we have diagnosed Nemalin, most of the time now congenital myopathies were more common type. What we see here is Fukuyama. It's a very common type. Nemalin, we have diagnosed, we have suspected one or two cases where they had severe contractures. Contractures are supposed to be a very prominent feature in these cases. And especially they will have feeding difficulties since childhood. They will come with history of aspiration. We have had the cases of, we have even suspected.
I don't know whether you slide on this or not, but Nemalin has 4 variants. In that adult variants, this fits. The problem with all these disorders is that most of them have some adult variants or something. So that rare atypical variant is difficult to lot in. But Nemalin myopathy definitely has four types. Have you put, Vedant, that 4 types of Nemalin myopathies?
Types I have not put, sir. Early onset, late onset with slow onset hypertonia, and intermediate, sir.
Yeah, this goes more in the favor of childhood onset or that intermediate onset. Where this fits, these contractures and other things are not written in the, especially in Nemalin myopathy.
What about though there is no mental retardation, I said about Fukuyama, where we have, they will have posterior fossa abnormalities in the CT, MRI, brain. Is it indicate? I don't know. I am not very well versed with that.
No, brain was not. I read this superficially, sir, but most of the other deformities, I couldn't find the adult variants, childhood variants. They're mostly present at the neonatal or infancy phase. Does Fukuyama, I am not aware. Does the Fukuyama can present?
We have presented from Madurai for 2 to 3 cases, sir.
Okay, childhood onset.
Yeah, suspect, proved Fukuyama.
The onset was in childhood?
Child, 9 months and a 2-year-old child. We have had diagnosed.
Yeah, this was much late onset actually. So later
both,
onset.
both had malformations in the brain. They are mentally, they are not, there is no delayed milestones or anything, but they had posterior fossa abnormalities. cerebellar malformations like that.
We have not done MRI CT in this case, so we have not done.
Ramakrishnan, what is your clinical impression, Ramakrishnan, based on this presentation?
Clinically, I thought of a limb girdle muscular dystrophy pattern only, sir, because there is a
Exactly.
wasting of medial group of muscles. There is specific involvement group of muscles was there, sir. It's slowly progressive. Clinically, I thought it is. I didn't suspect to be a congenital myopathy, sir.
Maybe. That we had a nagging sense right from the beginning that the spatial difference was very typical. Other than that, at least my differential was also limb girdle myopathy first, and the second was congenital myopathy. But that too also because of facial dysmorphism, that nothing else. This all signs definitely indicates to dystrophy.
Hello, Natarajan.
Yes, sir. Please, sir. Professor Zahir Ahmed side. Yes, sir.
See, I'm most impressed by three features in this patient. One, he's not a child. Second, he's got a myopathy which is limited primarily to the hip. And on top of it, it has a variable, it has a, what shall we say, misleading feature of a low motor neuron disease by the ankle dropping. And the last one is this dysmorphic high palate, which is, what do you put it?
Sir, you are not audible, sir.
The palate, which is very highly, the combination of this palatal abnormality, proximal myopathy, and the distal this thing, is it at all possible to entertain any other diagnosis other than Nemelin?
I think Vaibhav will have to answer that, sir.
Sir, the problem is here the congenital myopathy, nowhere the focal selectivity of muscle is not given, sir. And
yes, I agree with you.
Yeah.
But in a clinical setting, when you have this proximal myopathy, which involves the quadriceps much more, well, there are other myopathies which the quadriceps can, with the spread, if you wish, to distally, which gives you which suggests that this might be a low motor neuron lesion, but it is really not. With the high arch palate, can you at all give a differential diagnosis? If there is a pediatric neurologist on the forum, I would like to hear from him.
Yes, sir. There are three. They contributed. Meghandan, Ramakrishnan, Senthil Kumar. There are three pediatric neurologists at least, sir. Maybe there are more. I have not seen. There are. They have contributed, sir. Sir, Meghandan, sir, do you want to add something more?
I agree with Professor Zahir, sir, that we cannot just completely digest what Nemelin report has come, because it doesn't answer a few questions of what we get clinically. We still, and there is a family history of autism which is linked, because when there is a congenital malformation, again, we have to go into the history in detail, and the absence of childhood problems like feeding difficulty, especially very commonly, which we have seen. 2 to 3 times they get admitted with pneumonitis, with aspiration. We have even suspected myasthenic syndromes in those cases. And contractures, again, absence of contractures, again, not very much in favor of Nemelin clinically. Yes. So clinically still we have to think of, though the report has come like that, we accept the report and then think of other things also before proceeding further. I think as the presenter pointed out, it's better to go for muscle biopsy and go for muscle staining.
And the trouble here is that congenital myopathy, there is nowhere selectivity is written. Here the selectivity has been established by the MRI also. The MRI clear cut shows the selectivity of muscle. So this is very dicey here actually.
Natarajan,
sir,
what I'm not up to it, but what does the MRI show in Nemelin? What has been published about it?
Yeah. So, sir, Bidan, you will please present that. Can we proceed to that slide? Yeah.
So here actually we can see that facial dysmorphism, that is elongated face and high arch palate, it is actually can be present in Nemelin myopathy, centronuclear myopathy,
I think it is, excuse me, I think it is characteristic of Nemelin myopathy.
Yes, yes, I agreed.
Thank you.
As we are talking about that muscle selectivity, actually there is a article which written it written actually that in some subsets of Nemalin myopathy, tibialis anterior is selectively involved more than plantarflexors, and we can see that in nebulin gene mutation, the vastus lateralis, vastus intermedius, rectus femoris, and gracilis, these are actually selectively involved with relative sparing vastus medialis and gluteus maximus.
The pattern was fitting in, but not exactly fitting. Like rectus femoris was spared in this case,
Yes,
and gluteus maximus was involved in our case.
Anodine receptor, that is actually gluteus maximus is very severely affected, and in case of bridging interference mutation, there is interlink mutation, bridging interlink mutation, actually there is selective sparing of the thigh muscles, so we cannot tell that actually there is selectivity is not present in congenital myopathy. Here we can see that nebulin is affected in tibialis anterior, as I told.
But again, here our posterior compartment was more involved than the anterior compartment.
Yes, sir. Yes,
It was
sir.
reverse. Yeah.
Yes, sir.
But soleus is also involved.
Sir?
Soleus is also in that previous
Yes,
slide.
soleus in
soleus
our patient, soleus is involved. These
Yes.
pictures are actually not from our patient. It was taken from this journal. The first part is showing actually Gimori trichrome staining, which showing this red
Bracket fibers.
hello
red ragged fibers, sir, is saying.
Yeah.
red colored Nemalin rods, and in electron microscope we can see that there is very beautiful Nemalin rods we can see here, and some on core disease also there is we can see the central halo. Core disease can be central core or multi-mini core disease. In central, it is a picture of central core which is showing actually myofibrillary disruption with full absence of mitochondrial work, so impairing the fatty acid oxidation and phosphorylation, and this is the disrupted picture in the electron microscope. This is centronuclear myopathy,
Yes.
where actually there is central nucleus is there, and this is the electron microscopy which actually showing a single cell row with central nucleus. There is genetic heterogeneity in congenital myopathies, which showing actually one single gene mutation presenting with different type of phenotypes, as ryanodine receptor mutation can be present in Nemalin myopathy, core myopathy, centronuclear myopathy, and congenital fiber type of disproportionate myopathy. This ryanodine receptor mutation with congenital myopathy patients are very prone to the malignant hyperthermia. So our take-home message is proximal muscle weakness has very large spectrum. Congenital myopathy can present in late childhood. Vigilant history, careful clinical examination is the key to diagnose or clinch. And MRI can help in diagnosis and choosing the muscle for biopsy. Clinical exam sequence is very useful in diagnosis. Thank you.
And congenital myopathy can have selectivity of muscles also. This is the one thing I learned actually during this presentation.
Very good.
Yeah.
Very good. Excellent case presentation. The best part of this case is the patient is not worsening. Patient's activities of daily living is preserved. How are you going to advise this boy in future? Are you planning to do muscle biopsy in this patient?
Actually, sir, actually that patient with congenital myopathy who have respiratory compromisation, we have to follow them very carefully and very frequently. This is more within 3 weeks, sir, 3 months, and 1 to 3 months. And those who are not having respiratory compromisation, we can follow them 3 to 6 months. And this is actually a multidisciplinary approach with orthopedics, physiotherapist, neurologist also, and they will work as a team. It is not like a single arm management. And these patients actually luckily having no skeletal muscle abnormality, so we don't have to nag, don't have to think about that, but he can develop in future respiratory weakness. That time we have to follow him very frequently.
Hello, Bhupati.
Yes, sir.
Will you please ask what is the recent literature? What is the target structure in the muscle where
Yes.
nemaline affects? Do you understand my question?
Yes, I could understand, sir. Thank you, sir.
What is the target structure in muscle
Yes.
which in nemaline is affected, or that the chromosome is able to, chromosome produces the defect?
Yes,
Is it the muscle membrane?
yes.
Is it the mitochondria? Is it actin? Is it myosin?
Myosin.
Is it the linking thing?
Yes, sir.
Tell me.
Z bands and H bands are there.
Jet fiber, sir.
What part of the muscle, that is the microstructure is being affected with this particular chromosome? Did you read that?
The jet fibers are actually affected in there. In the muscle fibers, muscle cells, there is jet fibers is affected actually.
Yes.
That fiber.
Yes, sir. See, there are many things to be, explored in this case. Why in this particular patient, the disease is only restricted to this muscle, and why this patient is, is not crippled. That is, in congenital myopathies, we have seen any number of congenital myopathies, nemaline myopathies, and the patient will ask Professor Makendan pointed out, as well as Professor Natarajan pointed out, these people will have the morbidity will be more, contractures will be there, and there will be a cognitive deficit will be there. These are all the clinical features which are lacking in this patient. I think muscle biopsy may help us. What it looks like nemaline myopathy maybe something else also. Anyway, you kindly follow this patient on long-term basis. And suppose if this patient comes and parents comes, or this boy asks, sir, will I get married? What will be your answer? How will you advise this patient? What is your advice?
Sir, this is a very tricky question actually, sir.
Common question I come across in my department.
Okay, sir. Sorry, sir.
From my patient. We ask, we invite opinions from Professor Makendan, Professor Ramakrishnan, and also your mentor.
Bhupati.
Yes, sir.
God forbid, if your daughter wants to marry him, will you allow the marriage?
No, sir.
That's it. You have the answer.
This fellow will ask. Somebody is there to give.
Fine, you may ask. But just as I said, suppose my daughter wants to marry him, will you allow the marriage?
I will not allow.
You may not allow. But that's the answer.
That is, people will come and ask usually. Thank you very much, sir. Thank you very much for your
very
excellent
welcome.
Presentation. Next, we will move on to
just one question, Bhupati sir.
Yes, sir. Yes, sir.
No, to Vaibhav, are you planning a biopsy in this patient?
I am contemplating. I am really confused, but I am contemplating it. Yeah, because
Pardon?
Because there are few muscle disorders where characteristic findings are there. I think we should go ahead with the biopsy and
To look
prove
for
it
red racket
possible.
fibers.
No.
Yeah, no, not Nemaline dots.
Professor Natarajan,
Yeah.
Yes.
suppose if I ask you, will you ask for biopsy?
No, that's the question. See, you don't expect much from the biopsy unless you are specifically looking for something. As he said, if you are looking for
Yes.
nemaline rods and want to exclude nemaline myopathy, then yes, biopsy is going to be helpful. Otherwise, I don't think biopsy is going to contribute. That's what I wanted to know from Vaibhav, what he's doing.
Whatever, if you ask me, I'll say, yes, you do biopsy and record it. So suppose if some more cases come, how will you go, how are you going to complete this case as an academic in institution? See,
Unless there is something specific in the pathology,
yes.
just saying it's a myopathy is not going to help us. If you're looking for some specific features, then yes.
No, I will possibly go with this, with the biopsy, because here the characteristic, there is a doubt in diagnosis, number one. Number two, if we do the biopsy, there is a chance of getting a definitive diagnosis. So both this I am in the favor of going for the biopsy.
Professor Vaibhav.
I think
Hello.
Yes, sir.
it is ideal, sir, because there are a lot of atypical features in these conditions, because he has lived so many years. The myelomyopathy of this age group, adult type, is again very rare, so it's better to establish the diagnosis. And again, the atypical features and giving the muscle correct clinical histological diagnosis will definitely help for him as well as for his future, as well as for the family.
Hello.
Yes, sir. Zahir, sir, go ahead, sir.
Natarajan,
Yes, sir.
I think you and I have argued in the Institute of Neurology on what is to be done, but we didn't have the access for a genome study on him. Do you think this one, what genetic some chromosome analysis of what this will help?
Again, I would request Vaibhav to answer that, sir.
I think that's more important. Huh?
No, I was trying to find some geneticists. I am going to contact some geneticists in this regard. I will, before going to the biopsy, I will just contact some geneticists how to proceed in this case.
अब तो बहुत लोग कर रहे हैं यार.
Yes, sir. There is next generation sequencing panel है. बहुत लोग कर रहे हैं.
बहुत हैं यार.
Yeah.
I mean,
But again,
Vaibhav,
as
the only
Dr.
thing
Manikandan
you have
pointed
to do
out,
is to find out.
Vaibhav,
yes.
as the Ramakrishna suggested, Sanger
Yes.
sequencing was something which he suggested, which will be more
Yes.
Useful.
suited for identifying. So
Yes.
perhaps,
Yes. Yes.
So Natarajan,
Yes, sir. Please go ahead, sir.
thank you,
You
sir.
can go
Thank
ahead
you
with
very
the
much.
next case.
Thank you for all the participants. We will move on to next case, sir. I invite the next presenter.
Good afternoon, sir.
Yes, sir. Proceed, sir. Yes, doctor, please present.
Yes, sir. Good afternoon to all of you. Today I am present another case. Actually, this is a story of a 42-year male. He is a resident of Sundarban, West Bengal. He is born of non-consensus marriage. He is graduated up to BA. He is by occupation he is a farmer. He also doing work of guide for tourist, and he is a private tutor. And there is no any comorbidities, and the informant he himself. He presented with the chief complaints of painful spasm in the right lower limb since 6.5 months. He has a weakness of right upper limb and lower limb for 4.5 months. He has involuntary twitching movement for last 3 months. Coming to the first symptoms, he has a painful spasm in the right lower limb. First time he noticed at the night, midnight, this episode in the right lower leg. And he noticed that his calf muscle become stiff and there is some prominent over the calf muscle. And this lasted for 2 to 3 minutes only, and it's relieved with a massage, and the pain, the quality of the pain is spasmodic. And initially it was very infrequent, and over the few days it's become very frequent, and the frequency is initially is 2 to 3 times per week. Later it become 5 to 10 times in a week. And it's occur mainly in the night time, but as the disease progress, he noticed similar complaint in the afternoon also, mainly during after heavy strenuous exercise or work, mainly playing football or doing some other work. However, there is no history of any low backache, shooting pain from back. There is no any thinning of muscle. There is no any sensory symptom. There is no posturing of any toes or leg. There is no any stimulus sensitivity, and there is no history of drug use. Coming to the next complaint, since last 4.5 months, patient developed weakness of the right upper limb and the lower limb. And this weakness in the patient tells about this is a progressive in nature. And initially, he noticed there is difficulty in using the right upper limb while doing the heavy work. He feels heaviness and he feels difficulty to hold the spade as well as lifting the spade while doing the farmer work. And after that, he started to heaviness of the right lower limb, and he could not lift his right lower limb, and he can't get out from the bicycle. Gradually, his symptoms is progress, and he has difficulty in develops shooting football as before he can do, and due to this 1 to 2 times he becomes fall also due to during putting shot. For last 3.5 months, he noticed difficulty in getting up from Indian style toilet, and since after 15 days this symptoms, he develops slippage of chappal from the right foot also, which he tells this slippage of chappal is knowingly. For last 15 days before the admission to the Jipmer, he has difficulty in lifting the right hand for during food intake, and he has needed support for walking due to excessive tightness of the right lower limb. There is no history of loss of consciousness, language disorder, language problem, seizure, myoclonus, or any emotional lability. There is no history of any cranial nerve symptoms in the form of any facial deviation or any dysphagia. There is no history of clonus, flexor spasm, girdle-like sensation, bladder symptoms, or any ptosis or meiosis. There is no history of Hermite sign. There is no history of any root pain. There is no history of any other sensory symptoms. There is no history of wasting or frailness of a limb. There is no similar complaints in the left upper limb and lower limb. For last 3 months, patient develops some involuntary twitching movements. First time this twitching movements he noticed in the right arm. Initially, it was very infrequent, and as the time advances, this twitching movements will become progressed, and it's involved the right lower limb after 2 months. It's involved the left upper limb and lower limb also, and over the trunk for last 1 month. Now it is present almost continuously, and there is mild asymmetry is there. There is more this abnormal movement on the right side as compared to the left side, and it persists during sleep also. And patient himself narrated that he feels this involuntary movement, or he feels that there are some bumps that were moving under the skin, and since due to this some other person will ask what is this, why this happened, so he feels very embarrassing because it is visible over the cloth also. There is no history of higher mental function, cranial nerve symptoms, girdle-like sensation, flexor spasm, any autonomic symptoms like hyperhidrosis or anhidrosis. There is no difficulty in holding neck, turning side by side in the bed, no history of thinning of the limb, no history of fluctuating weakness. There is no history of generalized weakness or any respiratory complaint. Coming to the etiological negative history, there is no history of weight loss, weight gain. There is no history of fever, chronic cough, night sweats, hemoptysis. There is no high risk behavior or any blood transfusion. There is no history of polyarthritis rash. There is no similar events or like this previously. There is no history of drug intake, Siddha medication or any poisoning. There is no history of toxins exposure or heavy metal intake. There is exposure. There is no radiation exposure history, and there is no similar events in the family. Coming to the personal history, there is no history of any alcohol, smoking, or any other addiction. Bladder and bowel is normal. Appetite is normal. Sleep is normal. There is no past history of diabetes, hypertension, or any other chronic illness. Treatment history, there is no significant treatment history before admitting to the Jipmer. So, summary, this is a 41-year gentleman. He is born of non-consanguineous marriage. There is no comorbidities. He presented with insidious onset, chronic, rapidly progressive of the symptoms in the form of right-sided spastic hemiparesis with light lower limb spasmodic pain and muscle twitching, which he narrated that it is a worm-like movement and it is present on the both sides of the body along with the tongue. There is no history of any higher mental function, cranial, sensory, autonomic, cerebellum, or any extrapyramidal symptoms. So coming to the symptom analysis, actually patient, the first complaint is the transient spasmodic pain in the right calf. This pain, there are some possibility regarding this symptom. First differential is the cramp. Second may be possibility of spasm. Third may be the tetany or maybe the dystonia. So by again we can analyze the symptom. There is patient is telling this pain is spasmodic in nature and it lasted for a minute and it relieved with a massage. And this there are no other places where he similar complaints like in the upper limb or other sites. He complain only in the bilateral calf, and there is he is telling there is bulging of over the calf region at the time of this pain. So by considering all these things, this for the possibility of cramp is most likely in this case, and the possible localization may be the anterior horn cell, root, nerve, or meta muscle. Coming to the second symptoms, actually patient has a weakness of a right upper limb and lower limb with spasticity. And there is no any history of loss of consciousness or language impairment, any cranial abnormality, or any bladder bowel sensation, or any other sensory symptom. So we can consider this a right spastic hemiparesis, and the possible site of localization is the corticospinal tract. Coming to the third symptoms, there are involuntary twitching movements over the limbs and the trunks. And patient himself narrated it is a worm-like movement. It is continuous in nature, and this is it is continuous in nature, and then it is feel like worm-like movement. So possibility of myokymia we can kept. However, other lower down differential may be the fasciculation. So possible localization is the anterior horn cell or nerve.
Hello everyone, this is Dr. Ramkumar. That's good. You can just now stop the presentation. I think you can get the comments for this symptom analysis about the DDs.
Okay, sir.
Yes, sir. Please discuss this case. I invite opinion from the audience.
Sir, in view of the subacute onset, 4.5 months of duration or 6 or whatever it is, with a cramp-like pain and weakness of the right upper limb with twitchings, I would I would consider autoimmune disease as in the differential. Possibility of autoimmune disease has to be considered. The second differential would be for me like a myotonia. That would be my opinion at this juncture. Let me see the examination findings and get back to you.
But sir, there was no history of any myotonia or pseudomyotonia kind of symptoms. The symptom predominance are cramps and then this myochemic features like worms moving under skin with some weakness. So as you said, the first thing could be any autoimmune disease. Another thing is whether any possibility of any ALS like Mills hemiplegic variant could also be the possibility is there. So any other
in view of fasciculations affecting the left side also, I will also keep the antidohon cell ALS in mind. But ALS developing over a course of 4.5 months is very unusual. That would be my.
Yes, sir. Yes, sir. As rightly said, that's okay. Sir.
Is it an upper motor neuron lesion on the right side? Does he have a spastic hemiparesis? See, we have not gone to the examination yet. From the history, how do you conclude it's a spastic hemiparesis?
Actually, patient sir has complained of initially patient had the heavy work. He has found stiffness in the right upper limb, which over 15 to 20 days is progressed to the right lower limb also, while during and feels that there is underwater sensation. And after that, he has develops this difficulty in getting up from squatting and this silpy of slipper also knowingly. So, by considering this heaviness or stiffness or underwater like sensation, upper motor neuron.
No, that is only one of the differential diagnoses you can think of an upper motor neuron for those symptoms. Those symptoms do not by itself say that he has a pyramidal tract involvement. Without examination, I think that would be difficult to say. So
Yes.
before going to the etiology of the problem as to whether it is an autoimmune or not, first of all, where is the pathology? What is affected and where is it affected? That itself we are finding it difficult. Is it a spinal cord level problem, or is it a low motor neuron level problem, or is it a hemispherical problem? We have analyzed certain symptoms. Yes, certainly he has cramps, and by description, what it looks like a worm-like movement suggests it's a myokymia. And what started off and remained mostly as a right-sided problem, because of the myokymia, seems to be a bilateral problem. That's the only one which suggests that it's a bilateral problem. So I think we would have to wait for the signs to even be sure that there is a corticospinal tract involvement. Otherwise, it could purely be a low motor neuron problem. Again, seeing being a pure motor system involvement, it could be either a low motor neuron motor system involvement or a combination of low motor neuron and upper motor neuron motor system involvement.
Yes, sir.
But the presence of myokymia to this extent probably suggests it's more of a low motor neuron rather than an upper motor neuron. If it is myokymia.
So can I say something, sir?
Yeah, please.
Sir, fully agreed with you all the points. In these cases, examination is the very important, becomes extremely important. This patient was Hindi-speaking patient actually, and he specifically complained of this, what we call akadan. So he said heaviness and akadan of the limb on the right side, but there was no flexor spasm. So it is.
What is akada? Sorry, what is akada?
Akadan is stiffness, something of stiffness and tightness in the limb. So he specifically complained that. That is the only reason to keep spasticity. But yes, agreed. Sometimes we may not get the history of spasticity, which can be found only in examination. And in this case, the examination was the most important thing. But this was the only clue of the upper motor neuron examination on the history. There was no other clue.
Sorry for the interruption. Flexor spasms in the history can also be suggestive of upper motor neuron lesion.
They were not present.
There is no history of the flexor spasm in this case.
Intrinsic muscle disease inflammatory muscle disease or irritative muscle disease could also give rise to spasm. That may also mimic like, spasticity. The patient's interpretation is very funny and different, and we have to give
Yes.
credence to the present. But at present, there are no overt signs of corticospinal tract involvement from the history. So I think it is more of cramps, more of wriggling movement. All these things confined only. Maybe the pathology may be confined to anterior cell. Whether it is anterior cell, less. I think it is less likely in the anterior cell. Root, yes, root involvement. Nerve involvement, not uniformly all the nerve involvement, all the nerves. That too only one side. It is very premature to talk about this. Is it in the myoneural junction? Maybe. Or in the muscles? Maybe. So we'll have a open, broad view. We'll go to the examination side. After that, we'll decide.
Yes, sir.
Yes, sir.
So it is very easy to talk about many differential diagnoses, but we have to think it over, and we have to narrow our differential diagnosis after getting the findings, examining patient. From the history, it is very difficult at this juncture to say a particular, the region that is being affected. Anybody wants to localize the lesion precisely? Apart from the diagnosis, I do not want to make any diagnosis at this juncture. I have to wait. Mr. Natarajan, sir.
Sir, as I already said, the core feature being myokymia,
Yeah.
I would localize to lower motor neuron, unless otherwise they show me signs of an upper motor neuron involvement, which would mean only an additional feature. But that extensive myokymic movement, as described, which is the core feature, which is associated with cramps and perhaps some stiffness, which, as you said, we do not know what it is, what stiffness it is. It might be arising from the nerve, or it might be arising from a muscle pathology. So that we'll have to depend on the sign. So at the present time, I would go more in favor of a lower motor neuron pathology involving either the nerve or the muscle in view of the widespread myokymia.
I can call it as neuromyotonia. I can call it
Natarajan,
Yes, sir.
would you seriously consider primary muscle dysfunction when you are having myokymia?
No,
Sir,
no,
neuro-
sir.
And
No, sir.
I can understand you. I can understand the anterior cell or the peripheral nerve, but
Yes,
primary muscle dysfunction, is that possible?
not involving the muscle alone, sir. No.
Yeah, that's what I'm saying. You see, I do think a primary dysfunction because of the myokymia is excluded really.
Yes, sir.
Zahir, sir, is it a neuromyotonia?
But neuromyotonia is not in the muscle, Bhupati.
It's not in the muscle. It is in the nerve.
Neuromyotonia will be arising from either the root or peripheral nerve.
Yeah. Yes, that's what I'm thinking. Yes, sir. You can proceed, sir.
Okay, sir. So, by keeping all this after symptom analysis, we have some differential in our mind. Since patient has young male, so age is a little bit early, like 42-year male for MND, but male sex is a point in favor of ALS. However, by history, he has some spasticity or stiffness in the right side. So we can consider this maybe a UMN finding and element finding in the form of cramp and myokymia. And other points in favor of this ALS is there is no sensory, bladder and bowel involvement by history. The points against the ALS is there is no atrophy in the history, and there is somewhat rapid progression of the symptoms, and there is no bulbar symptoms. Is the age is young age, and the male sex. There is cramp, there is myokymia, and there are some points against this. Is there is asymmetric involvement, there is no autonomic symptoms, there is no any higher mental function, and there is no any hypertrophy. Our third differential is, however, it is the lower down, but we should cap this differential: cervical myeloradiculopathy, because the point in favor of this is the there is human signs and element signs, but there is no bladder bowel, no sensory symptoms, no Horner's respiratory symptoms. So this is lower down, but we should keep this in our DD. Shall I proceed, sir?
Please,
Yes.
please.
Coming to the general examination, patient is well built and well nourished. His BMI is 26.5 kilogram per meter square. His normal height to neck ratio. There is no short neck. Pulse rate, BP, everything is normal. There is no orthostatic fall in the BP, no neurocutaneous marker, or there is no Marfanoid habitus. Comes to neurological examination, higher mental function is absolutely normal. There is MMSE is 29/30. Cranium nerve examination normal. Atrophy, as we can see in the calf region, there is no atrophy. Myokymia, which is present on over all four limbs, right, more than the left, and over the trunk. In this video, we can see there is continuous undulating movements, rippling movements over the limb, and looking more rhythmic in nature. Shall I play once more video, sir?
So is
Yeah.
video visible? Can you play it once more?
Yes.
Sir.
Things to note in this video is this continuous muscle rippling, which is continuously seen on under the skin. Like
You'll be able to show the other shoulder muscles.
Saurabh, you have to comment about the distribution and the other hand also.
It is present over the both all four limbs. However, it is more on the right side and also on the trunk.
So you are able
You
to
put the video on the myokimic movements, please.
And show the trunkal movement also.
Can it be seen, sir? Is it visible?
Yes, yes.
It was also present in the right thigh and left thigh, but they were asymmetrical, more on the right side.
It's quite widespread.
Yeah, they're widespread.
Sir, is video visible, sir? Can I repeat once, sir?
No, it's okay.
It's okay, you can proceed.
Okay, sir. Okay, sir.
You proceed.
Motor system examination. Tone is there is spasticity on all four limbs, and there is the tone is more in the right side. In the if we this Grade according to Ashworth grade, it is 2 in the right upper limb and lower limb, and on the left it is 1 in the left side. And there is ill sustained clonus in the right lower limb also. Neck, coming to the motor junction in the neck, there is normal.
Just a minute. I just want to highlight it was very clearly asymmetrical and it was more on the right side. In fact, right side had a ill sustained clonus also. So that asymmetry and all 4 limbs tone increased, which was more on the right side.
Yes, sir.
So I just want to highlight that here because this is what we are looking for. The tone is extremely important in this examination. Proceed, sir. Proceed.
Yes, sir. Coming to the neck movements, flexion is normal, extension is normal, rotation, lateral bending is normal. Comes to the power in the upper limb, at the shoulder joint, abduction, adduction, flexion, extension, all there is decreased power, +4 on the right side and normal power on the left side. Similar in the elbow, around the elbow joint, at the flexion, extension, supination, pronation, there is +4 power on the right side and 5 on the left side. At the wrist joint, flexion, extension, radial and ulnar deviation as compared to the left side, that power is normal. Hand grip also weak on the right side as compared to the left side. Coming to the lower limb power, at the hip joint, there is around at the movement abduction, adduction, flexion, extension, internal rotation and external rotation. At all places, there is +4 power on the right side and there is normal power on the left side. And the knee joint also, there is +4 power on the right side and normal on the left side. Ankle dorsiflexion, plantar dorsiflexion +4, and on the left side is +5. Inverse one is weak, mild weak on the right side, and left side is normal. Trunk movement is definitely normal. Different movement, extension, flexion, rotation is normal. Coming to the reflexes, first superficial reflex, corneal conjunctival reflex present bilaterally, abdominal reflex present, cremastic, bulbocavernous reflex are present. Plantar, here we have to highlight, it is extensor bilaterally. Deep tendon reflex, there is absent jaw jerk, there is brisk pectoralis major bilateral, finger flexion is present bilateral, Wartenberg sign is present bilaterally, Hoffman reflex is present bilateral, and there is brisk reflex in both sides, biceps, triceps, supinator, knee, ankle, all of the reflexes. There is no asymmetry in the reflex we have found on the motor examination. However, there is no primitive reflexes. All primitive reflexes are absent. Sensory system is normal, coordination normal. There is no any other abnormal movement apart from that myoclonus. There is spine, cranial, and meninges. All examination are normal. Coming to the gait, there is mild circumduction gait we can say on the right side as compared to the left side. Coming to the systemic examination, cardiovascular system absolutely normal, respiratory system, respiratory rate 14 per minute, abdominal thoracic, chest expansion is okay, equal in the both sides. There is no indrawing of intercostal muscles in the respiration. There is no paradoxical breathing. Per abdomen, there is soft. There is no any organomegaly. So again, we can summarize after the examination finding. There is 41-year gentleman born of non-conscious marriage. There is no comorbidities present with chronic
rapidly progressive symptoms of both UMN and LMN features. UMN in the form of spastic hemiparesis and LMN is the form of cramp and myokymia without any higher mental function, cranial, sensory, or autonomic or cerebral involvement.
Bhupati,
Yes, sir.
hello.
Yes, sir.
Ask him whether he saw the tongue.
Yes, sir.
Did
Are
you
these
examine
things?
the tongue, sir?
Yes, sir. There is no any fasciculation on the atrophy of the tongue also.
What is the, what about the plantar?
Plantar, plantar.
Plantar.
Extensor,
Already.
bilateral extensor.
Extensor.
Upgoing.
Okay.
No fasciculations on the face.
No, sir.
Have you seen that?
Yes, sir.
Yeah, please go ahead.
So after the examination finding and
Did you see the, why don't you present with your investigation findings? Why don't you present the investigation findings? What investigations you have carried out?
yes, sir. Just after again summarize, we will go to the investigation workup, sir.
Correct. See, there is nothing much to summarize here.
Okay,
It's an
sir.
asymmetrical presentation of pure motor system involvement, characterized as already you said, spastic pyramidal involvement on both sides, right more than the left, with features of lower motor neuron in the form of myokymia and cramps. So it's an sorry.
Yes, sir. Yes, sir. Sparing the cranial nerves.
Yeah, that's all. I'm coming to that. So it's an asymmetrical presentation of upper motor neuron and lower motor neuron, right more than the left, predominantly, not exclusively motor system, localizing at the cervical level or high cervical level. So we'll have to consider a myelopathy, high cervical myelopathy,
Yes.
involving both UMN and LMN. The point is, which of the pathologies high cervical is going to produce such extensive myokymia? That is going to provide the answer as to the etiology.
It is
Natarajan.
short duration, rapidly progressive.
Yes, sir.
Natarajan,
Yes, sir.
see, this is a diffuse involvement of the cord.
Yes, sir.
The anterior extension of the lesion is the anterior horn cell, possibly.
Yes, sir.
If not, you have to say he has got a fairly diffuse involvement of the peripheral nerve.
Yes.
Okay, sir.
In
Yes,
addition
sir.
to the cord involvement.
Yes, sir.
Correct?
Ama, sir.
Then I think very few things will fit into this category.
As was pointed out earlier, we'll have to consider, yes, sir, we'll have to consider toxic involvement. We'll have to consider
toxicity is one.
Yes,
heavy metal toxicity.
Yes. Adan சொன்னார் சித்தா ட்ரீட்மெண்ட்லாம் எதுவும் எடுக்கல. I pointed out that no drug history was there.
Yes, sir. Yes, sir.
But that is something which we'll have to probe into. The other is whether it's a part of an autoimmune problem.
Autoimmune problem.
Yes. So these are the two high in the list. Then we'll have to proceed accordingly, sir.
Yes, sir. The patient.
It is a secondary motor neuron disease also. Secondary motor neuron disease also you have to think, sir.
Yes, sir. That is where autoimmune come into.
And
And
the main interesting thing about this thing is that it has all the features of this peripheral nerve hyperexcitable syndromes, but there are some things like the presence of bilateral pyramidal signs, and then the presence of asymmetric involvement. All those things keep this case interesting.
Plantar extensor, bilateral plantar extensor,
Sensor.
and spastic quadriparesis. The problem, one more, the drug history was very thoroughly probed into this case. We asked all the family members. We asked multiple times this patient. We asked about vitamins or unknown strength tablets, everything, whatever, and at multiple time points.
Organophosphorus exposure.
That because he's a farmer occupation, that organophosphorus poisoning was also thoroughly investigated. I think he will come to etiology.
Sleep disturbance. Sleep disturbance.
Yes, sir. There is no sleep disturbance. I have mentioned, sir, this thing. There is no sleep disturbance, or there is no any psychotic symptoms like delusional hallucination or any abnormal behavior, sir.
Thank you. Thank you. Anybody wants to comment further, please?
Exposure to Siddha medicine, sir.
No. No.
No, sir.
I am diagnostic, sir.
I have mentioned that there is no history of Siddha medication or any OP poisoning or any drugs or toxins or heavy metals, sir.
Yeah, you did mention. Okay.
Saurabh, he had
Thank you,
insomnia, right?
Thank you.
No, sir. Actually, I was saying the history that insomnia is not. He didn't have any insomnia, sir.
Okay, fine.
Shall I proceed, sir?
Please.
Yeah.
Now coming to the investigation, first the laboratory workup, all the routines, including the CVC, renal parameter, liver function parameter, thyroid parameters are normal. Serum electrolyte, especially sodium, potassium, calcium, magnesium, all are normal and done multiple times. CPK is 92, that is also normal. We have found there is mild impaired range blood sugar at HbA1c 6.3. ANA is negative. There is no cardiomegaly or any paracardial abnormality on the chest X-ray. ECG 2D echo is normal. Viral markers, HIV, HBsAg, anti-HCV all are negative. Serum VDRL is negative. We have done CSF, and CSF shows albinocytological dissociation in the form of elevated protein 133 mg per dl. However, there is no cells and other things in the CSF are normal, including the encephalitis, meningitis, all other panel. Coming to the NCS, totally normal NCS, both sensory and motor conduction along with the late responses also is normal. We have done EMG, and EMG shows frequent fasciculation.
Raj, but I think the EMG, you can just play the video from the beginning, and then I think we can get comments from the floor.
Yes, sir.
Play from the beginning.
More in favor of physics than myokymia.
Sir, it's so
Exactly. And this EMG was done by two different neurologists at two different times and was adequately, all the muscles were sampled. Even the muscles which showed direct myokymia, but this was more in favor of fasciculations rather than myokymia.
Yes.
The myokymia was not seen, neither myotonia was seen nor myokymia was seen. Anyone else? There were very frequent fasciculations were seen.
Profuse physics and
Yes.
pyramidalism and pyramidal signs.
Yes.
They are physically.
So rapidly progressive ALS-like presentation.
Yes.
But why the, hello,
Yes, sir.
Yes.
why increased protein in the CSF, Natarajan?
Sir, we'll have to
It is
look for
ALS?
other. Sir, we'll have to look for causes of this ALS-like presentation. I think.
Right presentation, that's right.
Yes, sir.
yes.
We'll have to look for other causes. Search for other causes.
You are still to discuss the cause during hospitalization, right?
Yes.
Sir,
Yes.
you have finished investigations?
No, it is still.
What else do you want, Bhupati?
Sir, I want some more. That's why I'm waiting.
Present.
Antibodies.
MRI. MRI.
Yes.
Yes, you present. Yes.
Yes, sir. Shall I proceed, sir? It is coming
Yes.
in
Yes, 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 please go.
the EEG we have done. Actually, we have not done polysomnography for any sleep behavioral abnormality due to some technical reason. However, EEG shows there is no interepileptiform discharges, there is no any abnormal slowing, and there is no any feature suggestive of encephalopathy. As we, our differential is the peripheral nerve hyperactivity, maybe possibility of MOR1. So we have done this thing, but we didn't find any positive finding. CCT thorax and abdomen we have done to rule out any mass lesion, including the thymoma or any of lung or any other bladder abnormality. Malignancy. But CCT thorax is definitely, it's totally normal. We have done autonomic function test as we are considering our one of the DDs is the peripheral or hyperactivity, which shows autonomic dysfunction. We have found there is heart rate variability abnormality. Standard deviation, this shows 20 millisecond, but a normal value is between 30 to 93. So some possibility, all other parameters are normal in the autonomic function test. So some may be possibility of some parasympathetic dysfunction. Otherwise, all other component of the autonomic function test are normal. Coming to the brain imaging, MRI brain done. That doesn't shows very gross changes, but if we carefully look along the corticospinal tract, there is hyperintensity along the bilateral corticospinal tract. We can see there is hyperintensity around the corticospinal tract, bilaterally symmetric, and there is no contrast enhancement of the hyperintensity. In the coronal section also, we have seen there is hyperintensity along the corticospinal tract, which we called it Garland sign.
Garland.
Garland signs. Then we have ordered antibody for this patient, and actually patient is not affording for a whole panel, so we have sent the LGI and Casper2, which comes to the negative. However, contactin 2 and other autoimmune worker we have not sent, including the GAD also. So after the admission in the JIPMER, patient admitted in December and his symptom start in the June almost. So after admission, patient was evaluated, and we after doing the history examination and the investigation workup, we think there is some possibility of autoimmune pathology, and we have started on IV methylprednisolone, followed by the oral steroid. And this patient was admitted almost 25 days in our institute, and during the course of hospitalization itself, patient itself narrated and objectively we have noticed there is improvement in the symptoms, and patient there is nearly 50% reduction in the twitching, and patient initially at the onset initially when admitted, that time he didn't walk independently, he needs support in getting from the bed and chair, and also from the squatting position. So after starting steroid, patient symptoms improve both objectively and subjectively.
Sir, you have shown MRI brain.
Yes, sir.
But it would have been better. You haven't shown the MRI of spine,
cervical spine.
spinal cord.
Spine.
Cord.
MRI cervical spine.
MRI cervical spine, spinal cord, I didn't see. So that will be better investigation. But also, you haven't done that is a tumor markers. I am expecting that tumor markers should have been done.
Actually,
And, yes, sir. Tumor markers should have been done.
tumor markers
And,
we have done.
and any disease, acute, this is a subacute onset and it is a progressive short duration problem. Definitely, if you treat the patient with the IV methylprednisolone, there will be improvement. But this patient needs a still more, I mean, he has to be investigated properly, and also some of the, I mean, specific investigations must be done like tumor markers. And also, there is no harm in doing the MOG antibody as well as the Aquaforin-4 antibody in this patient.
Actually, sir, I forget to mention here. Actually, we have sent CEA level, CA 125 and prostate specific antigen. And these three are normal in range, sir. Brain and spinal cord MRI we have also done. That is also normal, but I forget to put the slides here, sir. That's
Sir, cervical spine MRI was normal, sir.
Saurabh,
yes,
would
sir.
it be worthwhile doing a GAD antibody on him?
Yes, sir. We are planning, sir. Actually, we are planning to send GAD and contact to along with other also. So, but patient is not affording, so we have sent only this two, sir. That is the most frequently associated with the PNS, sir. So, by considering the this money as a factor, we sent only two antibodies.
Sir,
But
one,
just GAD alone.
Actually, but in future, sir, this patient is in our very close follow-up. So we have just planned to send other antibody also, sir, in the future.
Sir, if I may suggest one more.
Yes, sir.
Yes, Sujan.
Yes, sir.
CSF yes, sir. CSF VDRL also would not be totally out of the place. I think CSF VDRL is also important, and a specific test for syphilis also. Considering the significant cytoalbumin association, neurosyphilis also should be ruled out.
rapid plasma reagin or TPHA would be.
And CSF VDRL, of course.
CSF VDRL, of course, would be sensitive. TPHA and rapid plasma reagin test.
Yeah.
And here in this case, there is since there's an improvement with IV methylprednisolone, I would definitely think of a cell surface membrane antibody rather than a intracellular or nuclear antibody. So paraneoplastic is a remote possibility here.
Of course, should be considered. Paraneoplastic, neurosyphilis, and HIV should be considered in the potential diagnosis. Thank you.
Also, repeating the antibody studies, that is autoantibodies, as somebody mentioned, it is worthwhile in repeating. So initially it may be negative, but at a later date it may be positive, and it is worthwhile repeating. And close observation follow-up is necessary in this.
Even if the serum antibody is negative, CSF antibody can be positive.
Yes, yes, sir.
Depends on which antibody you are looking for.
Yes.
For some antibody, serum is more than adequate. So it depends. See, that's why you'll have to selectively narrow down which antibody we are looking at.
Yes, sir.
Sometimes antibody mediated neurological disease can be there without any antibody. It may be negative, but it will respond nicely to
this presentation. I would think of a VGCC antibody compared with the combination of Casper and LGI. These are the two.
That is what they look for already, and they found it to be negative.
You still want to rule out organophosphorus, chronic organo. You can just do some chorinesterase study and then find out, because being a farmer, forgetting about other things, the typical fasciculation, he gets chronic fasciculation with spastic weakness. I still feel something toxic has to be ruled out.
the patient improve like this, sir, with the steroid.
There is only an apparent improvement. I don't think steroids has definitely done some miracle in here.
Good, good, good. We have to, that's why we have to follow the case. I mean, and also.
See, if suppose even if the antibody is negative, after some time the CSF antibody becomes positive, is this patient require a long-term immunosuppression in the form of azathioprine or mycophenolate or whatever?
Ramkumar and Vaibhav, your comments, please.
Yes, sir. Another one thing which can think about is about cramp fasciculation syndrome, sir. Because this PNH, it is a spectrum actually. It starts with cramp fasciculation syndrome, then Isaacs syndrome, then Morvan syndrome. This cramp fasciculation syndrome presents similar to the Isaacs and Morvans, but but the difference is mainly regarding this EMG wise. This fasciculation functions will be more rather than neuromyotonia or myochemic discharges. And there are some reports of the initial presentation of this ALS starting as cramp fasciculation syndrome and later progressing to ALS kind of picture. So we think the cramp fasciculation syndrome is also a definite possibility in this case.
Yeah, but what is the underlying etiology?
So in cramp fasciculation syndrome, there are the articles even in Muscle and Nerve. It states that in cramp fasciculation syndrome, the antibodies need not be positive in always the case. The antibody positivity is more in Isaacs and Morvans, but in cramp fasciculation syndrome, the antibody positivity is very much less. So the absence of antibodies doesn't rule out, but other things are fitting into the cramp fasciculation syndrome.
Ram, did you find any MRI abnormality in the cramp fasciculation syndrome?
That's what, sir. Usually it is normal. That is the interesting in this case. What is interesting is this lot of things are points towards cramp fasciculation syndrome. And a few of the things are this MRI abnormalities and then this presence of asymmetricity. Those are the things. But the hyperflexia could be present and stiffness could be present in cramp fasciculation syndrome. But some of the red flags are this asymmetric involvement and the presence of this MRI abnormalities, which are not that much depicted in cramp fasciculation syndrome.
What is the current treatment he is getting?
Actually, sir, we have started on, sir, this membrane stabilizer in the form of carbamazepine and gabapentin. And we have started 3 days of IV methylprednisolone, 1 gram per day. And followed by, we have started 1 gram per day oral prednisolone.
No. What do you mean by that? How long? 3 days, 3 days pulse therapy followed by?
Actually, sir, a patient is 7 to 10 days we have kept on oral prednisolone.
That is initially.
After discharge, sir.
Oh, all right. So at present you are giving both pulse and regular therapy.
Hello, sir.
At present you are giving both pulse and regular methylprednisolone therapy, is it?
No, sir. We have given only one time IV methylprednisolone. Now patient is only on the oral prednisolone therapy, sir.
Since how long?
Almost, sir, 2 months, sir. 1.5 to 2 months, sir, now after discharge.
Okay.
Actually, yesterday, sir, I also talked with the patient. His symptoms is not very much progressing. His symptoms are same only, that thing. Yesterday I talked for some information, so I again inquire how your symptoms. So it is not worsening or not improving also, but it is like we have some days was improvement was there.
So another thing is cramp fasciculation syndrome is that some of them are will settle down with carbamazepine and all those drugs, but some of them may require immunomodulatory therapy. I think maybe it needs to be followed up and put on some immunomodulatory therapy also. In the meantime, I suggested some paraneoplastic antibodies, more panel could also be done for this patient to rule out any, even any FDG PET also might be needed.
So next month, sir, patient follow-up is scheduled, sir. We will assess and we are planning to send other antibodies also. And
Sir, any more points from the audience? Anybody wants to say a final word? Professor Natarajan, Professor Zagir, sir.
Final word is excellent presentation of 2 good cases and very well discussed. And thanks to all of you Professor Zahir, Professor Bhupati, all the participants, Professor Ramakrishnan, Professor Mahikandan, Professor Vijayan, Anand, all of you who took part. See, it's a lively discussion and that's more flattering. So thanks to all of you, sir.
Thank you very much.
Thank you.
Thank you for the presenters.
Thank you very much, sir. Very nice cases.
Their
Thank
guidance.
you, Professor Vaibhav and Ramkumar and the presenters.
Thank you, sir.
Thank you for the opportunity, sir. Thank you.
Congrats to Pondicherry Neurologists Association.
Jipmer.
Jipmer Pondicherry. Thank you.
Thank you.
You very much.
Thank you.
Thank you, Sun Pharma, for everything.
Thank you.
Thank you,
Thank
sir.
you.
Thank you, Vaibhav.
Thank you. Thank you, sir.
Thank you, sir.
Thank you, Ram. Yes.
Thank you, sir.
Very nice cases. Thank you. Thank you.
Thank you, sir.
We'll meet next month.
Thank you, sir. Okay, sir.
Thank you. Thank you.
Good day, sir.
Thank you, Jyoti.
Thank you so much, sir.
Yes, sir.
Manish, you can stop that. Mr. Manish. சந்தோஷ் நான் பேசுறது கேக்குது?
கேக்குது சார்.
கேக்குதுண்ணே.
கேக்குது சார். கேக்குது சார்.
சரி, ஓகே. சரி,
கேக்குது சார். நான் பேசுறது கேக்குதா?
இல்ல இந்த மணிஷ் ஒருத்தர் இருப்பாரு பாம்பேல, அவரு கட் பண்ணாருன்னா கட் ஆயிடும்.
இருக்காரு பட் லைன்ல இருக்காரு.
சரி, ஓகே, பை.
சரி.